Professor Rashad Bishara, one of the famous vascular surgeon here in Egypt. He said, do you assess reflux in transverse or longitudinal view? I think the general school here in Egypt that we only assess reflux on longitudinal view, not in transverse view. But what is your opinion or your policy?
In the groin, I always assess it in longitudinal. But when you go down the great saphenous vein, I think it is much more easy to do it in transverse. If you put the I don't see if you see me moving, because in my image I'm frozen, but you see me really doing movements. Okay, when you put the transducer
no movement,
on the, if you put the transducer on the skin like this and then make this, you have a good angle to the flow. But if you have the longitudinal view like this, the flow is parallel to the transducer and you will lose information. You know, the Doppler effect is only possible if there is an angle, and the angle you can achieve it moving the Doppler. And then, so in the junctions, I use the longitudinal, and in the transverse of the vein, I use the cross section.
Okay, we have another question from Professor Khalid Al-Affas. He's one of the famous intervention radiologists here in Egypt. His question is, what is the difference between systolic and diastolic reflux?
By definition, you never will have a systolic reflux in the great saphenous vein. You can only have a systolic reflux through perforating veins when the deep vein is obstructed. So during systole, normally the flow goes up through the main veins, through the saphenous vein, through the deep veins. When you make a systole, either the vein is obstructed or you have an orthograde flow. If you have a reflux in systole, you have an obstruction somewhere. But normally our patients have no obstruction, they have reflux. So in systole, you provoke a flow that is to the heart, and then you observe the behavior of the blood in diastole. What happens after you have mouthed the blood? You wait and you see if it goes down longer than 0.5 seconds, there is a reflux. If not, there is no reflux.
Okay, I will take one final question from Professor Ahmed Gawish. He's also one of the very famous vascular surgeon with a special interest in venous intervention. His question is, what would you do for patient presenting with refluxing accessory ASV with only dilated non-refluxing great saphenous vein?
I would not treat
so presenting
yes, I would not treat
patient
the great
presenting
vein
with refluxing.
Yes, but only the accessory. I would then only treat the accessory. I mean, if it is refluxive, I would treat it. And depending on the diameter and on the amount of flow, I would do an endoluminal treatment if there is an interfascial running. And if it's tortuous or extrafascial or very thin, you can do a foam sclerotherapy. That depends a little bit on the finding. But if it's refluxing, I would treat it always in the complete setting. And if the saphenous vein is healthy and only the accessory, I would only treat the accessory.
Okay, we have a last question from China. I think there is Dr. Reno Chai. He raised his hand. If Dr. Khalid can put him to the podium to ask the question himself. He raised his hand. I think he's speaking from China. Your mic is on. You can introduce yourself and ask your question. Dr. Rina Chu.
Rina is from Australia. She's Chinese but lives in Australia. She's also get up at 4 o'clock in the morning. Thank you.
Okay.
Very honored.
Okay.
I'm very honored.
Okay.
But I don't see her.
Can you open your mic, Rina? Well, yes, she can speak now. Yes.
Can you? I'll just like to say, yeah, we are 4:45 in the morning. I just wanted to tell Erica, I'm enjoying your talk very much. It's answered a lot of my questions. I am a medical trained doctor from China, but now I work in Australia as a phobology sonographer. So I spend a lot of time scanning patients.
Thank you.
Okay.
Thank you.
Welcome. So that's it, Professor Ayman. The mic is back to you.
Okay, thank you, Omar. Thank you, Erica. It was a very interesting talk and very interesting interaction. Thank you. Now it's my turn to introduce my dear friend, Mark Whitley, consultant of vascular surgery in Whitley Clinic. As a fact, the name Mark is always accompanied by first. He's the first man who did endovascular surgery in United Kingdom, 1999. He invented the TROP procedure for treating the perforator. He is the first surgeon to microwave in Europe, February 2019. And he is the first in United Kingdom used HIFO ecotherapy in May 2019. He is a member of the editorial board of Journal of Vascular Surgery, Venous and Lymphatic, and he is already published 4 books, and he has more than 120 peer review. Really, I myself asked him to take some pictures to put in my chapter in vascular surgery in your book. Thank you, Mark. And now he is going to talk about ablation treatment of varicose vein, thermal and non-thermal, what histology and immunochemistry has taught us about mechanism of action. Mike is yours.
Thank you very much, Dr. Ayman and Dr. Omar. Thank you very much for inviting me. I'm thrilled to be able to talk to everybody, and I hope everybody's staying safe with this horrible COVID time we've got at the moment. Thank you also to Varicose and Prime for putting on this tremendous time so we can meet all our colleagues, even though we're all stuck at home. So today I'm going to talk to you, as you've heard, about ablation treatment of varicose veins and thermal and non-thermal. As you've heard, I've been given a lovely introduction by Dr. Ayman, and I've written some books, and we also run a thing called the College of Phlebology, and we have a venous registry, which are all welcome to join, where we're trying to keep everybody as good as possible and get the best results, because we all claim we have good results. It's nice when patients feed back through a registry and tell us whether we are giving them good results. So why do we use endovenous techniques at all? Well, as we know, the simplest form of varicose veins, we know this isn't common now, but the simplest form is of reflux in the pelvic veins out through the saphenofemoral junction, if you just heard from Dr. Mendoza, down the great sinus vein and into varicosities. And the main treatments that we use these days is to try and stop the reflux. We all know there are some difficult cases, but this is the basis of all varicose vein treatments. In the past, we used to use the flush suture ligation. Those of us who wanted to try and reduce recurrences used to use non-absorbable sutures here after Glass's work from Ireland and close the fascia, and we'd get the bruising. And as we've just heard, the trouble with this is we get not only